بسم الله الرحمن الرحيم. Pulmonary diseases in immunocompromised non-HIV patients. Clinical assessment. Pulmonary disease is a significant cause of morbidity and mortality in the immunocompromised patients, and its diagnosis and management are challenging. In the United Kingdom, this is encountered most commonly in the setting of immunocompromise secondary to cytotoxic chemotherapy, hematological malignancy, immunosuppression, post transplant, particularly renal and hematopoietic stem cell transplant, including bone marrow, cord blood, and growth factor stimulated peripheral blood transplantation, prolonged corticosteroid use, and HIV. Most pulmonary disease presents in a similar manner in the setting of immunocompromise with fever, dyspnea, dry cough, chest pain, and often hypoxia. This non-specific clinical presentation combined with the larger number of possible causes makes reaching a precise diagnosis difficult. The diagnosis remains unclear in up to 10% of cases, even at the autopsy. For causes of pulmonary infiltrates in the non-HIV infected immunocompromised include the following: infectious causes and non-infectious causes, neutropenia or impaired neutrophilia secondary to leukemia or cytotoxic treatment, bacteria, Pseudomonas aeruginosa, Staph aureus, Streptococcus pneumonia, E. coli, Klebsiella, H. influenza, and nocardia, fungi including Aspergillosis, Candida, and mucormycosis. Impaired T lymphocyte function secondary to transplantation, cytotoxic treatment, high dose steroids, lymphoma, fungi, so PCB, leukocystitis caridae, Cryptococcus neoformans, Candida, endemic mycosis. Viruses include cytomegalovirus, herpes simplex, varicella zoster. The bacteria include mycobacteria, listeria, legionella, and nocardia, and parasites such as Toxoplasma gondii. Hypogammaglobulinemia or impaired beta lymphocyte function secondary to myeloma, acute and chronic lymphocytic leukemia, lymphoma. Encapsulated bacteria include Streptococcus and H. influenza. Considerable overlap exists between immune deficiencies, however, the pattern of infection will be further modified by prophylactic treatment, as for example, cytomegalovirus and pneumocystis carinii prophylaxis. The non-infectious causes of immunosuppression include pulmonary edema following renal transplant or HSCT, ARDS secondary to sepsis, drugs, transfusion-related acute lung injury, aspiration, and Griffith syndrome following HSCT. HSCT stands for hematopoietic stem cell transplant. Drug-induced disease causes include ATRA, which stands for all trans retonic acid, and anti-thymocyte globulin, azathioprine, bleomycin, busulfan, carmustine, chlorambucil, cyclophosphamide, cytosine, arabinocyte, hydroxycarbamide, liposomal, liposomal amphotericin B, belaflam, mitoside, albistrixate, and sirolimus. Respiratory evolved from underlying disease include lymphoma, leukemic infiltrates, lymphangitis, connective tissue disease, leukostasis with very high leukocyte counts in leukemia. Pulmonary embolism may be complicated by secondary infection. Clinical and radiological features may be confused with invasive aspergillosis, may be more common after renal transplant. Radiation-induced pulmonary disease, pneumonitis, typically following lung radiotherapy, may be delayed and triggered by later chemotherapy treatment, so-called radiation-recall pneumonitis or organizing pneumonia (OP). Diffuse alveolar hemorrhage may complicate leukemia at hematopoietic hematopoietic stem cell transplant (HSCT). Similar clinical presentation to that of pneumonia. Hemoptysis is rare, and the multilobar chest X-ray over CT infiltrates. Diagnostic criteria include exclusion of infection, progressively bladder returns from valve of the three different subsegmental bronchi, and more than or equal to 20% of alveolar macrophages hepatocidrine filled, and may require several days to appear. Reported mortality ranges 30 to 100%. Idiopathic pneumonia syndrome following hematopoietic stem cell transplant, breathlessness with hypoxia and multilobar chest X-ray and CT infiltrates, infection excluded with bronchoalveolar lavage, and ideally a second later investigation, that's to say, repeat bronchoalveolar lavage or lung biopsy, diffuse alveolar damage or interstitial pneumonitis on biopsy, mortality more than 70%. Engravement syndrome comprises fever, ARDS, and erythematous rash during marrow recovery post hematopoietic stem cell transplant, bronchiolitis obliterans syndrome (BOS) following allogenic hematopoietic stem cell transplant from sibling or unrelated individual, occurs only extremely rarely following autologous procedure, typically associated with other forms of chronic graft versus host disease, e.g., cutaneous gradual onset of dry cough, dyspnea, and chest X-ray often normal, fixed obstructive spirometry with FEV1 below 75% predicted, and more than 10% decline over below 2 year, FEV1 over FBC ratio below zero point 0.7, and residual volume more than 120% predicted, air trapping and the bronchial dilatation on HRCT, should request exploratory images, exclude, add to treat airways infection. Cryptogenic organizing pneumonia, post-transplant lymphoproliferative disease may complicate allogenic hematopoietic stem cell transplant or solid organ transplant, most commonly lung, pulmonary alveolar proteinosis, pulmonary veno-occlusive disease, pulmonary cytolytic thrombi, pulmonary metastatic calcifications may complicate chronic renal failure and rarely progress after transplantation. Chest X-ray shows single or multiple nodules or patches of consolidation may not appear calcified, and CT typical diagnostic right hemidiaphragm disinfection. Right, right hemidiaphragm dysfunction is common after liver transplant and usually not relevant clinically. The clinical assessments of pulmonary complications or pulmonary disease in non immunocompromised or immunocompromised non HIV patients. In the history, the underlying cause of immunocompromise and the timing of respiratory disease onset may provide clues to the diagnosis. The rate of the disease onset may also suggest possible causes. Acute onset, let's say below 24-hour, bacterial pneumonia, viral pneumonitis, pulmonary edema or hemorrhages, or PE or ARDS should be considered. Subacute onset, let's say days, fungi such as pneumocystis carnii or aspergillus, bacteria such as Nocardia or Legionella, viral such as cytomegalovirus, drug-induced pneumonitis should be excluded or should be considered. Chronic onset weeks, the malignancy and the mycobacteria fungi should be considered. The chest examination may suggest the extent of pulmonary involvement, although this can be misleading and there are often no abnormal signs, e.g., leukocytes, carinae, or bacterial pneumonia in the setting of neutropenia. Assess fluid status. Pulmonary edema is common following transplant. Extrapulmonary involvement may be helpful in suggesting pathogen, e.g., cutaneous lesions, herpes simplex, and varicella zoster, necrotic lesions from Pseudomonas and other gram-negative bacteria, mycobacteria, and fungi, subcutaneous abscess in Staphylococcus aureus and Nocardia, CNS involvement, Pseudomonas aspergillus, Cryptococcus, Nocardia, Mycobacteria, Streptococcus pneumonia, Haemophilus influenza, Varicella zoster. Chest X-ray appearance is very variable and may be normal. Now we are speaking about investigation after clinical assessment, investigation of the pulmonary disease in immunocompromised non-HIV patients. First investigation chest X-ray. Appearance is very variable and may be normal or show consolidation, nodular infiltrate, or diffuse shadowing. Chest X-ray is of limited diagnostic value and appearance are non-specific and atypical presentations are common. The first choice diagnosis based on chest X-ray is correct in only one-third of cases. Chest X-ray may be helpful, or chest X-ray may, however, be helpful in monitoring disease progression and response to treatment. Blood and pleural fluid, if available, sampling for microscopy and culture. Consider blood cytomegalovirus viral load (PCR), galactoman component of Aspergillus cell wall, beta-D-glucan component of Candida, Aspergillus, adipocystitis cell wall, urinary Legionella antigen also included. The sputum examination is often of little diagnostic value in immunocompromised patients with exception of TB. We should send sputum for acid-fast statin. We should send sputum for acid-fast stain and mycobacterial culture. Fungi stain and culture. Induced sputum has low yield for PCB in non-HIV patients. The degree of hypoxia is often not appreciated. Measure O2 saturations and consider ABG. Severe hypoxia tends to be more commonly associated with infection due to bacteria, viruses, or pneumocystis than with mycobacteria or fungi. If immediate antibiotic treatment required, immediate empirical treatment with broad spectrum antibiotics prior to further investigation should be considered depending on the nature of immunological defect and the local hospital policy. In general, neutropenia patients with fever are at significant risk of developing overwhelming sepsis and should receive prompt amniotic and should receive prompt antibiotic cover, irrespective of the chest X-ray appearance and the presence or absence of respiratory symptoms or signs, and more invasive diagnostic procedures can then be reserved for patients who deteriorate or fail to improve within a period of observation, e.g. 2 to 3 days. In non-neutropenic patients, depending on the clinical circumstances, it is often possible to withhold treatment until definitive investigations have taken place. Further investigations, more invasive diagnostic techniques are usually required for definitive diagnosis, including CT chest specific indications not yet defined and may not be needed in typical cases of bacterial pneumonia or PCB, useful in identifying location and extent of pulmonary disease and aiding invasive sampling procedures, often detects pulmonary disease in the presence of normal chest X-ray and considered if respiratory symptoms or unexplained fever but normal chest X-ray may be diagnostic, such as PE, as for example CT pulmonary angiogram, lymphangitis, carcinomatosis, invasive aspergillosis, a halo in which halo or air crescent signs present. Bronchoscopy with Bell. First-line investigations consider early in management diagnostic in about 60% of patients overall, up to 70 of patients with infection, results in changes in treatment in about 50% of cases overall. Complications are rare, useful in the diagnosis of bacterial pneumonia, PCB sensitivity 80 to 90%, cytomegalovirus sensitivity 85-90%, specialosis sensitivity 50%, TB malignant disease, diffuse alveolar hemorrhage, and alveolar proteinosis. Bronchoalveolar lavage, fluid analysis, routine microscopy, and culture for patients for culture for bacteria and additional stains and the culture for fungi, mycobacteria, nocardia, silver, and immunofluorescence stain for leukocytes, respiratory viral screen, parafungal, panfungal PCR, galactoman. Consider additional tests on bile fluid cytology, including flow cytometry for malignant cells, inspection for sequential bile Returns as cytology for hepatocidrine-laden macrophages of alveolar hemorrhage suspected, Cryptococcus antigen detection, cytomegalovirus PCR, Toxoplasma gondii PCR. Transbronchial biopsy has a slightly higher sensitivity than bronchoalveolar lavage for the diagnosis of infection, but carries a risk of bleeding and pneumothorax, which can be serious complications in this patient's group. It is not usually performed at the initial bronchoscopy, although may be considered, that's to say, if the lymphangitis is suspected. Lung biopsy. Consider as a second line investigation if bronchoalveolar lavage not diagnostic. Options include repeat bronchoscopy with transbronchial lung biopsy is useful in the diagnosis of malignancy, mycobacteria, fungi, organizing pneumonia, and the drug-induced lung disease. Video assistant thoracoscopy or open lung biopsy have a greater diagnostic yield than transbronchial biopsy, although it's unclear if this can be directly transplanted or translated into an improved survival. Results in a change to treatment in below 50% of patients and complications may be serious. Percutaneous image guided fine needle aspiration, FNA, or biopsy for investigation of peripheral nodules also can be included in the lung biopsy techniques. Treatment of pulmonary diseases and immunocompromised non-infectious non-HIV include antimicrobials, diuretics, steroids, supportive treatment, and lastly, surgery. First, antimicrobials. Depending on the clinical circumstances, antimicrobials may need to be started prior to definitive investigations, although blood cultures should always precede antibiotic treatment. Choice of antimicrobial depends on the underlying condition and the local hospital policy. In general, most neutropenic patients are treated with broad spectrum antibiotics, providing both gram positive and gram negative covers, as for example, piperacillin tazobactam. Antifungals are considered of a slow response to treatment or subsequent deterioration. Consider adding vancomycin if MRSA is possibility. Treatment for cytomegalovirus and pneumocystitis pneumonia is associated with significant side effects and ideally should be based on a definitive diagnosis. In annual patients who are strongly suspected to have PCB, treatment can be started immediately as BEL pneumocystitis cerevisiae stays remains positive for up to 2 weeks. Antituberculous treatment should only rarely be administered in the absence of a microbiological diagnosis. The diuretics. Fluid overload and pulmonary edema are common following renal transplant, and hematopoietic stem cell transplant, and typical clinical and radiological signs may be distinguished to consider trial of diuretics. The use of steroids, despite lack of randomized controlled trials, evidence prednisolone 1 mg per kg per day, PO or methylprednisolone 1 gram IV daily for 3 days is often considered in the treatment of the drug or radiation-induced lung disease, engraftment syndrome, diffuse alveolar hemorrhage, and idiopathic pneumonia syndrome following hematopoietic stem cell transplant. Ideally, exclude underlying infection prior to starting steroids. Prednisolone 40 to 80 mg daily PO is also recommended for the treatment of pneumocystitis pneumonia in patients with respiratory failure, bronchiolitis obliterans syndrome (BOS), following allogeneic hematopoietic stem cell transplant is usually treated with increased immunosuppression, typically oral prednisolone 1 mg per kg per day with a rapid tapper, together with FAB therapy, which stands for inhaled fluticasone, azithromycin, and montelukast. Again, FAB stands for fluticasone, inhaled fluticasone, azithromycin, which is given typically 20-50 mg 3 times weekly, and the montelukast. Superadded airways infection is common and should be treated aggressively. Consider treatment of the gastroesophageal reflux, pulmonary rehabilitation, inhaled LAMA, and extracorporeal photophoresis and lung transplantation in severe or progressive bronchiolitis obliterans. Bronchiolitis obliterans. Supportive management. Administer supplementary O2 or high flow nasal oxygen to maintain saturation in ranges of 94 to 98%. Respiratory failure in immunocompromised patients is associated with a poor outcome mortality following intubation, and the mechanical ventilation ranges 60 to 80, 60 to 100%, and carefully consider appropriate ceilings of care, including suitability for intubation and mechanical ventilation. Last, the surgery. Surgical wedge resection or lobectomy may be considered in the treatment of invasive aspergillosis, either acutely for lesions adjacent to pulmonary vessels that are judged to have a significant risk of massive hemoptysis, or at a later date for residual lesions at risk of reactivation with further chemotherapy. That is all about pulmonary disease in immunocompromised non HIV patients.